this is a talk that we've been waiting for a while, and we're very fortunate to be hearing from Dr. Finley today. Lung cancer screening, we've known for a long time that it can save lives, but there have been questions about implementation and everything from funding, the government level, all the way to the logistics, and then the downstream effects for the non-cancer things that people find. That can be a thing that's very overwhelming. But Dr. Finley has been sort of uniquely positioned to help us navigate through this as a province. He's the clinical lead for lung cancer screening in Ontario. He's a third-generation thoracic surgeon who, after doing his medical training between Ontario and BC, did a Master's of Public Health at Harvard to develop a broader understanding of healthcare systems and how things can be implemented to affect change from the individual patient care level all the way up to the government level. So hopefully he's going to be able to provide us with some clarity about how we're going to move forward as a province and as an institution today. Everyone, please enjoy.
Wow. All right, well, he stole my slide too. So, see. There you go. So this is my grandfather, who was a thoracic surgeon, my father, who's a thoracic surgeon, and I am also a thoracic surgeon. So I'm the only third-generation thoracic surgeon in the world that I know of. And so I still have my grandfather's operative reports from the 1940s when they're just learning to do lung resections. And so one of the first lines is that, they did an 8th interspace thoracotomy, which is about 3 ribs lower than we do it right now. He said, this is not the easiest way to do this operation. And then they would sew it backwards. They would go taking the things reverse of what we do nowadays, and they would use chromic gut, which is a suture that absorbs in about 14 days. So they'd sew the main pulmonary artery closed with a suture that's only there for 14 days. So everything was different and it moved along. And so all they had was a chest x-ray. So they would take someone to the operating room with a chest x-ray. They had tons of futile thoracotomies. My dad was a thoracic surgeon during the sort of the era of minimally invasive surgery. And so when I was a kid, the VHSs, which you probably don't even know what they are, but there's these tapes that we used to watch stuff and you'd record your television shows on them downstairs. You'd just as likely get, the A-team as you would get a, minimally invasive thoracotomy, because you'd use the same videotapes. And so you'd put the videotape in thinking you're going to watch a television show and you would see blood and guts across the thing. But, mirroring that, with these lesions have gotten smaller and smaller and smaller, CT scans have gone, more prevalent, and our understanding of lung cancer and how what its behavior and what we can do about it and how we can prevent it has really evolved. When you think about the 1960s, 50% of people smoked in the 1960s, and now we're down to about 11% daily smokers in Ontario. So I'm going to talk a little bit about the background of lung cancer screening, the value of lung cancer screening really from an absolute survival advantage to a cost effectiveness, how you design a program, how we design a program in Ontario, where we are in Canada in the future, and we'll do it all in an hour, no problem. Okay. So lung cancer is a big deal. So I think that, this is a bit of a mixed audience, but lung cancer kills more people than breast, prostate, and colon combined. It gets 5% of the funding and kills 25% of the people. It gets 5%, it gets 1/5 the funding of breast cancer. So it's absolutely entirely socially stigmatized. If you, we'll go on talk in a second. There's a 20% survival advantage for lung cancer screening. If I gave you a pediatric disease and told you I had a screening intervention that would save 20%, decrease mortality by 20%, it would be funded tomorrow. This took 10 years to get funded. Currently, about 72% of people are smokers, but 28% are non-smokers. The biggest trends that we see from increasing lung cancer risk is in non-smoking women, typically associated with pollution. We think forest fires are going to be a big deal coming up in air quality. But really still to this day, 70% of people show up with advanced disease. But when you find it early, our cure rates are very high. And certainly, we now have minimally invasive surgery. We have more focused radiation. And really, it's a time of great optimism in lung cancer. And certainly, I sit on the Canadian Cancer Society Statistics Committee. And lung cancer actually has the highest year-over-year survival improvement of any cancer. But yet, when we look between provinces, there's a 15% stage-adjusted survival difference by what province you live in. So if you live in a maritime province, you're far less likely to survive lung cancer. If you live in the Northern Territory, you're far less likely to survive lung cancer than you are if you're in a more urban part of our country. So when we look at survival, if we look at the early stage, you have an incredibly high survival. And as you go up the stages for lung cancer, it gets worse and worse and worse. Well, it's also not felt equitably across our country. So I did a report with the Canadian Partnership Against Cancer, looking at equity in cancer, and really we found that geography, poverty, and race have a huge role to play in survival for lung cancer. So when we look at First Nations, Inuit, Métis, urban, Indigenous peoples in Ontario, you see a dramatic survival difference in our province. And so I was over at the World Cancer Conference in Geneva and met with people at the World Health Organization, and we were talking about how we're going to work towards the World Health Organization's development goals for non-communicable diseases. And really, they put a target of 30% reduction. And when you look at cancer, it's lung cancer. Lung cancer is the vast majority of the developed world of mortality. And so we plotted out how we're going to get there, how we're going to get to that 30% reduction in mortality. The heavy lifter is lung cancer screening. Lung cancer screening is going to, we think, is a generational opportunity to improve survival for lung cancer. So why do we screen? So we screen things because we can find it at an earlier stage, and then we can do something about it. And we know that there's high risk factors that we can increase our likelihood of finding a disease. And so we find a high risk group, we screen them, and we're able to intervene and improve survival. But for the longest time, people didn't think that we had that. So when you look back to the 1970s, there's all sorts of trials looking at chest X-ray. And chest X-ray was universally found to be not helpful at screening for lung cancer. It's just not good enough. So then we moved forward, and then along came the LCAP study, and really looked using lung cancer screening. Started using low-dose CT scan to look for lung cancer, but it didn't have a control arm. But it was able to find a lot of early stage lung cancers, and that improved survival, but they didn't have a comparative. So moving forward to 2011, the NLST, this really was the first randomized control trial that showed survival improvement for lung cancers. And they were pretty simple in how they evaluate people. They just said 55 to 74, more than 30 pack years, quit within the last 15 years, you're in. You get a CT scan every year for 3 years, done. And so what did it do? It showed about 20% improvement in survival. So this was revolutionary. But you remember, this is 2011. We're in 2024. We currently have 5 sites in Ontario doing lung cancer screening. They do it in BC. And they just announced in Nova Scotia, and everyone else has a small pilot. So you can see that level of social stigmatization. Like any big revolution in medicine, if people do it in North America, they have to do it in Europe. And so in 2020, the Nelson trial came out of Europe, slightly different. Age category is a bit broader. Smoking criteria a bit different. Did the CT scans at 1, 3, and 5.5 years. They really looked at, they had a early AI looking at their screening CT scans to evaluate volumetrically how things are going. Interesting, I found like radiology used to be super popular to match into when I was going through because they make lots of money. But now it's like one of the lowest matched specialties, because I think everyone realizes that AI is going to take over that profession within our lifetime. Regardless, they showed about a 24% reduction in survival, or improvement in survival by lung cancer screening. And really, this was that second huge piece of evidence that said, why are we not doing this? And that sort of got people off the couch. Every major society has come forward with guidelines suggesting that we should do it. Please ignore the Canadian Preventative Task Force, which I'm sitting on their recent iteration, because they're the only one in the world that capped it at 3 years. Everyone else thinks it should be done yearly. From a cost effectiveness standpoint, I think people originally said that it's going to be too expensive to do lung cancer screening. It's entirely not my patient. It's absolutely cost effective by any metric you're going to put forward, whether it's 100,000 for quality. Really, in most places, in particular, if you do smoking cessation, it's highly cost effective. When we look across the country, as I said, BC announced in its province-wide, it's centrally run, so you basically just call one number. The scans are centrally read, it's all just run over the telephone. Smoking cessation is done on the phone as well, which is less effective, but broadly available. Alberta has a small pilot, but ironically, even though they don't actually have a lung cancer screening program, our government's announced that they're getting a screening CT. They'll drive around the province screening people, even though they don't have a program. So they just announced that a couple weeks ago. Saskatchewan, Manitoba, nothing. Ontario, we have 4 centers. We now have 5 centers with a plan to go to every major thoracic institution in the next 2 years. Quebec has a pilot. Nova Scotia just announced province-wide. Newfoundland has nothing. New Brunswick has nothing. Territories, even though the territories have the worst per capita lung cancer rates, nothing. We tried to get Nunavut in a Calios to go, but they said they did not pass. So implementation of screening. So it's great when you come up with something, say, okay, we should screen for lung cancer, and then someone turns to you and say, okay, now do it. It's actually logistically really hard. So I put to you to find someone more enthusiastic about lung cancer screening than me. It took me 6 months to get this place up and running. It takes a lot of effort and a lot of meetings. So how do you do it? So I'm going to break it into different chunks. So basically, you need to recruit people. You need to find out a group of people that you want to screen. You need to probably embed smoking cessation. You have to make sure the radiology isn't just someone reading off the corner of their desk. Then you have to seamlessly on the back end move people through to do something about it. Because if you fall and fail apart at any one of those, it's a problem. So how you get people? So it turns out for screening that if you just open up screening breast, prostate, colon, lung, whatever, rich people show up. And poor people don't. And so when you're talking about equity, lung cancer is a disease of poor, more socially disadvantaged people. And so you actually have to work really hard to find people who are geographically disadvantaged, or they're working 2 jobs, they can't come during the day. If you're in Brantford, there's no public transit from Norfolk to here. And it just takes a lot of effort to find the people that you want to screen. So we're looking at all sorts of innovative methods to try to find people, but typically the more effort you put in, the better you do, but you have to work extra hard to find the same number of people from those disadvantaged people. Navigation, again, and I'm sure you've all worked in different offices, different communication strategies. If you're relying on your assistant, who's got 17 other things to do to try to track down these people, it's just not going to happen. So you need to have people at the desk whose job it is to do this with a consistent plan. The other one that I think Dr. Tunks alluded to is you find things by accident when you scan with CT scans, and I'll talk about percentages in a bit, but you need to have a plan in place, and what are you going to do when you have accidental incidental findings? Risk assessment. So we talked a little bit about how when they did the NLST, when they did the Nelson, what they basically said is you smoke 30 years, smoked a pack a day, you're in. We realized that you can actually do better than that. Martin Tamamaki published in the New England Journal, used basically that if you ask other questions, family history of lung cancer, occupational exposure, history of COPD, you can actually get and race. You can actually get a much better model, and you can actually screen less people and find lung cancer. And so that's what we did in Ontario. But it also means actually that the barrier to entry is not 30-pack years, but as you'll see in a second, 20-pack. So you actually say, hey, if you smoke on a daily basis for 20 years at any point, come have a conversation with us. And if you have COPD, if you have other risk factors, then you get in. And then it's also a changing landscape because there's so much dynamism. There's a word there. In this field, the U.S. Preventative Task Force called out, they broadened the criteria from 50 to 80. So by limiting to 55 to 74, we're actually missing a lot of people that could potentially benefit. So this PLCO model which is the one that we use in Ontario and that most of the world has taken on because it's sort of published and validated, really shows a greater predictive value than the traditional criteria. And so, but you can saw it off at different points. And so most schools actually saw it off at 1.5 in 6 years. So if you have 1.5% in 6 years chance of getting lung cancer, you're in most of it. In Ontario, we're 2%. We were the first out in Canada, and so picked up a higher threshold. But there's certainly moved a foot in the Ontario setting to broaden the age criteria and drop the percentage, but currently it's 2% at 6 years. Smoking cessation. Basically, as you all know, it's a pain in the butt. No one wants to have the conversation. It's super unsexy. But the harder you work, the more effective it is. And so if you just phone someone on the phone and says, hey, you should stop smoking, you have about a 5% chance of making someone quit smoking. We have an opt-out smoking cessation policy. So you are enrolled in smoking cessation the day you come through. and if you can do it in person and have multiple visits and offer the nicotine replacement and other medications, you're far more effective at stopping smoking. Radiology, I'm sure you like I have read CT reports from Welland or Simcoe and realized that not all radiology reports are created equal. Like the 3-line, the lungs are fine, doesn't help you so much. And so you have to have standards. So you have to train people and make sure that they go through the process. And they also report systematic work. And so we currently use lung RADS, which is probably the international standard, which basically is just a graded scale of how great am I. It's everything from do another scan in a year all the way up to someone to assess them. You want your radiologist to read it enough to be consistent. I'm sure Ryan Rebello could read CT chest and then an MRI brain and a broken bone and do a good job of it. But for most of us, you need to do more to be better. And so you want a radiologist who does sufficient enough volume. And we actually have a whole radiologist whose whole job is to evaluate the radiologists, train them, and make sure that they're reporting consistently. And then there's a whole graduate program to enter. And then you need something like that. You find lots of stuff by accident. And NLST was 24%. When we started, Ontario was 30%. And if you have the radiologist talk, they can drop it down to about 8 to 11%. Actionable incidental findings, and that's things like emphysema, coronary artery calcification, kidney cancers, whatever. You just have to have a plan in place on who's taking care of it. I'm running through this quickly, so if you see something brilliant on there, won't stop and stop me, but there will be time at the end of it for lots of questions. So, this can be really high, and if you don't manage it, can sort of take down your cost effectiveness and make your program not effective. And not least of which anxiety. This is a very stressful situation for everybody involved. We had one feedback lately where the nurse phoned the patient, said, congratulations, your scan's fine, you don't have cancer, hooray. But they didn't mention, but you do have coronary artery calcifications and these things, and those were brought up by the family doctor appropriately. You just got to make sure that you frame it correctly at the beginning, all the way through your conversation. Diagnosis. 4B and 4X, it's a bit of an arbitrary thing, but 4B and 4X are the ones you actually think people have cancer. That's about 2.5% of people. They go on to be evaluated in lung depth, which doesn't mean they necessarily have cancer, but those are the people that have a threshold enough to have cancer that they just move on to the next level. And sort of like those of you that have gone through pregnancy screening blood tests, by telling people a priori, this percentage of people are positive, and you go on this, by understanding the next couple of steps, even if you don't get up there, it helps to relieve some of the anxiety. So what do we do in Ontario? So Ontario, it was a huge political battle, and it was a pilot for the longest time, and it had 4 different sites: Ottawa, Lakeridge, UHN, Health Sciences North. Hamilton just started last year, or this past year. Ottawa, interestingly, really struggled with volume, so they implemented a spoke and hub model where they have the same radiologists reading it, but they've brought the care closer to home, and that's been a very effective model, and it's the model that's being run out across the province. So we've just started here. We're opening in St. Catharines and Brantford as our spoke sites, and that's going to be the model really across the province. BC is a different model, which is that it's centrally run. All the images are read centrally. They just pull the images in, and so but with our current model, I think that what's going to be long term is really it's going to be run out of the different centers. So how did we do in our pilot? I'll talk a little bit about how we moved it from a pilot to a program. So we recruited about 8,000 people. 94% got risk assessed, which means they talked to the nurse and told them the risk factors. About 70% of those are eligible to screen, and then a proportion of those went on to get screening. And you should have to educate people, because people are disappointed if you refer them to lung cancer screening, they don't get it. So I think that's one of the educational things going out there. You're able to proportionally get the same number of Indigenous people in the program as they are representative in the population of Ontario. I don't think that means we're doing a good job. I think that there's a disproportionate of people of the First Nation, Inuit, Métis, urban Indigenous groups that smoke and are at risk, and so we should have a much higher percentage. And so I just wrote a grant to try to help with that, but we did an okay job, I'd say. Smoking cessation, 80% of people took the referral, but the people that varied from 10 to 20%, basically depending on how hard you work. Ottawa had the most intensive program, so they had about 20% quit rate. This is a terrible choice of colors for this, but about 3.5% of people had a 4B4X, so more than we thought. And really, this is attributable to that risk assessment model, because we actually found more cancers than anything else or the NLST using this whole risk assessment, so that it worked, and that modeling of risk assessment was a better way to do it. We found a bunch of early stage cancers. You do find some advanced stage cancers sometimes, those fast growing ones, but the vast majority of cases are early stage lung cancer. You'd love to do survival, but you can't get enough N in a single institution or even in multiple institutions to get to survival. You got to remember that the NLST had 35,000 people in it. But so this is, we're showing the secondary things that I think are beneficial. So stage migration, the vast majority of them are early stage. When we compare that to Ontario at the same time, you can see that really only about 30% of people have stage 1 or 2 lung cancer in the province typically, and we're at 80%. People stuck around. I think that's a suggestion of a successful program. We found things by accident. Typically on the first scan, we were able to reduce that down by being more consistent with our definitions and making sure that the radiologists are all consistent, and then a built-in plan. One of the fears was that we're going to have a bunch of invasive procedures and sort of benign disease, and we were able to find that we had low rates of interventions that were low rates of complications. People died, but it was unrelated to the screening or those complications. So this was all, a harm aspect of screening that was successful. It's very, very unlikely to have a interval cancer, i.e. in that year between your scans to get a cancer. So we thought we had the frequency right. If anything, if you have a couple of negative scans, it probably makes sense to stretch it out. And we're going to work about, that time frame point going forward as well. And then this whole concept of spoke sites was very successful. People had to drive less. There's better participation. We could reach those geographically disadvantaged people. If we open in Brantford, we're a whole lot more likely to get Brantford Simcoe than we are to make them drive to Hamilton. And that people like that navigational, people like to actually talk to human beings, it turns out. As that navigational model is actually very successful. People like to phone a person, have a single point of contact. And then people really like them. So there's 99% of people love the navigator. And that the other fear was, okay, this is going to overwhelm the hospitals. We're all going to drown. No one's going to get a CT scan ever again. And it's not the case. It didn't affect wait times for non-screen scans of the same urgency. It was a low volume relative to sort of the total case volume, and really it didn't affect anything. So that's good. From a rollout standpoint, we actually fund the hospitals in a case funding model. So for each scan they do, they get money, and it's non-contrast, and so it's actually super advantageous to the hospital to do this. So the new scanner at night, without contrast, without anybody around, can keep running. So successful, all check marks, top to bottom, on why we undertook it. And so then it came to the government, how are we going to make this actual program work? And this comes into sort of how we get things actually funded, and really takes a lot of work. Like you think, okay, it's intuitive, it's successful, now here we go, but it's a lot of money to get this up and running. And so it took a lot of political meetings to get it sort of across the line and to roll out. And I actually think that the single biggest factor is, the premier of BC, Horgan, got a head and neck cancer from smoking. Massively funded cancer in BC. Stephen Lamb, who'd been working on lung cancer screening for forever, finally got it greenlit for the province. Once BC was up and running, Ontario then flipped to go the province-wide at the same time. Once you had Ontario and BC going, and I convinced CPAC to give $13 million to the different provinces to fund the pilots. They've all started pilots. And once you have a pilot, it's easier to go to a program. And so it's basically been this horse trading, finding pockets of money and trying to tip various people to get it up and running. So before I get to that, so we're up and running here in Hamilton. Anybody who's smoked for 20 years daily, no matter the amount, can refer them in. We're on the hook for everything we find in the lungs. You're on the hook for everything we find by accident. So anybody can refer. You can even refer without a doctor, and we will find you. Well, we'll either contact your doctor and make them take care of it, or I become the family doctor. That's how it works. So I'm really motivated to make sure you guys take care of it. Essentially, 100% of respirology patients are probably eligible for lung cancer screening. And so send them on in. Happy to have them. More the merrier. Where do I think this is going in the future? I think artificial intelligence is going to take over the reading of these things. They do a much better job. It's like classic AI. I think that we're going to do a better job on an individual level of the screen intervals, how spaced apart they are. If there are a couple of negative scans, you probably don't need a scan every year. That your personal changing risk, you quit smoking, you started smoking, you got diagnosed with COPD, you find out your sister has lung cancer. It's all changes over time, and so I think that dynamic modeling needs to be there. But I think the biggest problem is stigma. I think lung cancer is highly stigmatized disease, and so I think that's what we're going to be working at for a long time to overcome. So in conclusion, really, lung cancer's here, lung cancer screening's here. Send all your patients. It's coming soon to Niagara and Brantford, so we can help service those geographically farther away. I think that the valid questions are: do we have enough CT volume? Do we have the manpower? This is where we require a lot of resources, opportunity cost. But I do think that this is a generational opportunity to improve survival. I don't think that there's an intervention you can find made for cancer that could change survival better than this. So I'm a big proponent, but I'm happy to answer questions. I got like 19 hats, so I can probably answer most of them.
Fantastic. I'm going to remind people at remote sites, if you have questions, please feel free to enter them in the chat. And I appreciate that you left time for questions here. Imran?
Hi, thank you for my name is Imran. I just have a question about time taking from actually screening to doing the assessment and meet criteria. How long does it take to get
Mm-hmm. Here, not long at all. You get called within a week, and you get your scan within a month. Here, if you're in Ottawa, they have a huge backlog, but they're unique in the province in their backlog. The other sites are
nodule, and you guys will arrange the follow-ups.
Correct. Yeah. So for everything that's found, we arrange all the follow-up scans, and if it needs to be sent off to DAP, we'll do that too. But we'll send a letter back to the referring physician. But we'll handle all the stuff that's found in the lungs. Unfortunately, all the actionable incidental findings are pushed back to the referring physician.
Is there an order support mechanism?
There is we've got a website, we've got a fax, you can do it internally, like there's 1,000 ways. And if you have any problems, contact, it's in Firestone, it's like literally down the hall.
Thanks so much. Congratulations on all, but this is huge. I was a PGY for resident doing combinations from respirology. You gave rounds here. It was a big talk about the servicing that gives us in the future. That we're in the future now. So congratulations. I think you're a big part of that. Selfishly, one of the things that comes up on all these, a lot of these CAT scans are interstitial lung abnormalities or ILAs that keep popping up, and a significant proportion of those patients go on to develop pulmonary fibrosis. Is there any thought across the country? I know in Vancouver, I believe, and as well as in Calgary, they're considering setting up ILA clinics where there's only ILD physicians there or sort of rapid access clinics, so that when these interstitial changes are picked up, they can sort of streamline the referral process there. Are you aware of any places that have set up a formal program for this type of thing that's been successful? Or
nothing formal. I agree with you completely that the more sophisticated we get and the bigger we get, there'll be more automatic pathways like coronary calcification, IMRAC, CIMRAC, cardiology. Like someone should at least evaluate that person. Same with interstitial lung findings. It's a missed opportunity if we identify and don't do anything about it, particularly in those early phases. So you want it, you can have it. Like we're going to be, we're going to be 50. We're going to probably be 1,500 scans here this year, and we think the spoke sites are each going to be 800 to 1,000 a year, and so new people. So you're talking about a couple thousand people, probably 5% rate of interstitial lung findings. So start hiring now, because we could just flood a whole person easily.
yeah.
Where the referral mostly comes from? Like, is it mostly from, say, respirologists here, or is it mostly from my family members?
Well, no, so when we started, everyone was like, Christian, please be quiet. We don't have such capacity. And so we started a very soft launch. So we talked to all the family doctors' offices. And then now we have more capacity. So we're being increasingly vocal. So we just did a photo shoot yesterday for things to go more public facing. and it's coming in layers, right? And so my second stop was I was doing a project with trying to remember the name of the program, but it's the RTs that go out to family doctors' offices and trying to optimize COPD management. And so we asked them to start sending us all the CT eligible patients. And so it's now, they say they have 300 for us. That are in. But there's grandma says they want to so it's a credit here to really suggest you send it.
And then just right, so your race is 5 year, there's 9%. And you measure it, it's one of the big problems is that they're right.
And we have one of our example metric that we want all the time to live at patients. And so they have no quality of the programs. They were lung cancer screening. None of this back.
No, that's right. I'm trying to use it. It was just does it. I guess I feel nice about it. I do all
It's programmatic, which I think is the reason for success. It's very clear retention.
Like you said, for girls are comfortable, but like, seems like a lot of people.
Oh, that's the guys. Not the leaders, most of the disadvantaged people that don't have family doctors or don't use their family doctor. And so, yes, that's fine. Doctor. So the whole program where you can come up, step back and go. When this was created, the family doctors that we want to own everything. It's very downtown Toronto. And we're family doctors. We'll see your patients and manage everything. We can have optics in the future and critical shortage. And so, take referrals from anybody. We'll either find a family doctor because they're willing to take people on, or I de facto take care of all the actual stuff. And then to let some other people step forward in that space. It was easier to go to family doctors. Now we have to do the hard work of finding the people that don't have family doctors. All those barriers and suspicions of care.
So I'm working to clear which inclusion is the
No, I could talk with him actually.
yeah. So one of the unique things about Manchester is the fact that if you've got lung cancer mortality in one area, the actual care is like 5% mortality. Next door, it's like 50% mortality. And often this hospital is continues to fall. It's lots of issues. I realize that the place that we need to be actually this requires especially all the area. So what they did was they set up a mobilized CT scan unit in the basics cover, and basically in that area, in the middle of the area, possibly they would do the quick drop later, do the CT scan there, and then.
And it's the interesting thing about that model, they also just making optimization. So it was a very Respirology. So they pull it to Walmart.
Yeah.
Running around. Legislature change the mobile units, and so it's part of our plan. We want to get the fixed sites with this wall up and running first, and then sort of get that last 5% driving in North Ontario. But right now, we want to have standards on it. Obviously, but you recognize that you recognize Asian that we we're interested in it, that we have order taking back the things that we have anyways, the Sherman purpose is one is not mentioned, and so lung cancer screening in a year coming up on a year and then enroll program. You're just following for modules. Okay. It's protocol says we got 600 on the ball. And we eligible full enrollment. So your preference would be that we enroll patients with levels of access. It's a judgment call in your case. If you're calling, you might order it for yourself, but if it's something that you're just gonna send back to the family doctor, probably just send it off to us and we'll take it.
Is there a separate access to the smoking cessation for this? Because like Dr. Young said, if we're just ordering something to scan, I don't want to put someone through the program, waste your time, all I want is.
I don't have a good answer here. St. Joe's does have, like, over the years, has had multiple smoking cessation programs. I think I've talked to like 3 different chiefs of staff about getting a systematic one. I don't currently know what your access is.
I have an odd semi-related practical question. Sometimes we get a report back of something that's very slow growing and they say do a scan in 2 years. You can't order a scan 2 years out in our system. Is there going to be a mechanism built into your program for that? Or when it gets to the 2-year interval, does it go back to the referring physician?
It's a very valid question. Yes, there's going to be a side door that comes in. So the other one we have is people we've cut out their lung cancer, we've been following them. When are we allowed to send them into the program? Or, you know, you don't want to exclude everybody who's had a CT chest in the last couple of years. And so we're trying to build in that portal. But it's so heterogeneous, it's less easy to do. So you can certainly refer them in at the appropriate time point and they'll get their scan. But it's so much work on your end, it's very worth it. And so we have to find a better.
All right. Well, I want to congratulate you on your successes. This has been a remarkable what you've been able to achieve in this province with our available funding and all the different players involved. And I want to thank you for speaking to us today. This was fantastic.
Thanks, John.